Pneumonia is the inflammation of lung parenchyma. So a patient of pneumonia generally presents with fever, cough with purulent sputum. For such a case, whenever the patient comes in the emergency department, we'll first have to check the oxygen saturation and maintain the oxygen between 88 to 92% by providing him with oxygen supplementation if needed. Further, history becomes very important in pneumonia to classify the types of pneumonia. Basically, if there is any hospital exposure in last 48 hours, we can classify it into hospital acquired pneumonia or otherwise into community acquired pneumonia. For hospital acquired pneumonia, most common organism that causes hospital acquired pneumonia is Pseudomonas. Apart from it, we can further check on most common 5 organisms, basically Pseudomonas, Klebsiella, E. coli, MRSA and VRSA. Community acquired pneumonia most commonly is caused by Streptococcus pneumoniae. Apart from Streptococcus pneumoniae, further it can be caused by Mycoplasma, Chlamydia, H. influenzae, Staphylococcus aureus and Legionella. So depending upon the history, we can diagnose pneumonia on the basis of clinical factors. For example, if the patient's symptoms are not severe enough and there are just mild symptoms and the patient is walking, then we can see if the patient has any exposure to Mycoplasma or Chlamydia. If the patient has a history of COPD, then we can go for H. influenzae. If the patient has a post-viral infection, then we can differentiate it down to Staphylococcus aureus. And if the patient is an old immunocompromised condition or on any immunotherapy, then we can differentiate it down to Legionella. Other causes for pneumonia can be Pneumocystis jirovecii, specifically with association of HIV, in which CD4 count is less than 200. Nocardia can be a cause. Non-tuberculous bacteria like Mycobacterium avium can also be a cause for pneumonia. Now, after coming to the emergency department, we'll first take the oxygen saturation and then go for chest X-ray. Chest X-ray is the most important initial step. On chest X-ray, we can have a lobar pneumonia or interstitial infiltrates. If it's a lobar pneumonia, we can be certain that the diagnosis is Streptococcus pneumoniae, and if it's interstitial infiltrates, then there will be patchy infiltrations all over the lungs, and we can be certain further by the culture also, obviously, but that certain diagnosis can be of any virus, Mycoplasma, Chlamydia or Legionella. Further investigations will be of sputum culture. Sputum culture becomes important as in Streptococcus pneumoniae we'll have rust colored sputum, and in Klebsiella we'll have currant jelly sputum. Klebsiella generally presents with history of alcoholics. Further, RT-PCR for COVID-19 nowadays and specifically in the endemic areas becomes very important. Also ABG, because pneumonia can further progress to respiratory failure if the symptoms are very severe. So repeated ABG analysis has to be done. Now some specific test like for Mycoplasma PCR is done, Legionella urinary antigen is done, and Pneumococcus jirovecii bronchoalveolar lavage is done. Also we can go for pleural tap for extensive investigation if no cause of pneumonia can be identified clinically or by the just said investigations. We can go with pleural tap. In pleural tap, if there are neutrophils predominant, we can be certain that the diagnosis is of the pneumonia is of bacterial origin, and if it is a lymphocytic predominant, then we can be certain that it can be a TB or viral. Now for the emergency cases, so the patient has come to the emergency department. We have checked the oxygen saturation. We have we have done the chest X-ray. Before all these, we have to go for some scoring systems, specifically Curves 65 and QSOFA score. Curve 65 decides the need for hospitalization, and QSOFA score decides basically if the patient has any high mortality rate or needs ICU admission. For Q-SOFA score, 3 factors are important: respiratory rate more than 22, which gets 1 point; altered mental status, which gets 1 point; systolic BP, which is less than 100, which gets 1 point. Curve 65. C stands for confusion, U stands for uremia more than 20, respiratory rate more than 30. B stands for BP less than 90 by 60, and 65 is the age. Now all of these gets 1 point each. If the score is between 0 to 1, it's a mild case. If it's between 1 to 3, it's a hospitalized. The patient has to be hospitalized, and if it's more than 3, then the patient can be sent into ICU directly. Now the treatment part. For community acquired pneumonia, outpatient basis, patient can be given azithromycin or doxycycline, 200 mg loading dose followed by 100 mg per day for 5 days. In ward, amoxicillin 500 mg 8 hourly has to be given along with clarithromycin 500 mg twice a day. In ICU, along with the basic antibiotics, we have to also start with respiratory fluoroquinolones and third generation cephalosporins. For hospital acquired pneumonia, most common cause is Pseudomonas, and further MRSA can be a most common cause. And for all other atypical causes, for Pseudomonas we'll have to give piptazo. If piptazo the patient is resistant with piptazo, we can go with carbapenems. For MRSA, vancomycin has to be given, and if vancomycin resistant case is present, we can classify it further to be a VRSA, vancomycin resistant Staphylococcus aureus, and for which we'll have to give linezolid. Further, for atypical cases, fluoroquinolones has to be added. For severe cases, steroids has to be added. Now, how to identify that if the patient is a severe case or not? pH has to be less than 7.3, lactate has to go beyond 4, and CRP has to be more than 150. Along with all of these, vaccination with pneumococcal vaccine has to be provided to all the patients more than 65 years of age and all the immunocompromised conditions, and redosing can be done after 5 years.